Perfect. Yeah. So thanks again, everyone, for joining us this morning. And we are very fortunate to have Dr. Corley with us to talk about the controversies in colon cancer screening. And I personally was very much looking forward to this talk. It comes at the perfect time with the controversies Nordic trial has generated. And I'm excited to be hearing Dr. Corley's perspective. Dr. Corley does not need an introduction. He's a renowned cancer epidemiologist and a gastroenterologist at Kaiser Permanente. He is the director of Delivery Sciences and Applied Research Program for the Permanente Medical Group. His research group has led multiple landmark epidemiological studies related to colorectal cancer. He is also the National Steering Committee Chair for the NCI Prosper Multi-Center Consortium. He is co-lead of the Screening and Prevention Working Group for the NCI's Cancer Research Network as well, co-founder of the NCI Upper GI Consortium Beacon as well. So with that, Dr. Corley, I'll hand it over to you, and I look forward to the talk. In the end, we will have a Q&A session. Anyone is welcome to unmute yourself or send your questions in the chat box. I'll be happy to read it aloud. So Dr. Corley, over to you.
Great, thank you so much for the kind introduction. My only regret is not being able to be there, like in person and having that type of interaction. I think there's just so many aspects of that of these ground rounds would kind of foster themselves to in-person interactions. Please do, if there are any points. I do have the chat open. If you have questions that kind of come up, there are a couple questions I would like to be able to pose to people before we start, just to be able to kind of get a groundwork. And in part, this is because of the controversies that are available. So if people are willing to either, verbally, which would be great, or put into the chat. The first question is for colon cancer screening. If you think on a population level, kind of like over the course of a lifetime, what you think the percentage reduction in colon cancer mortality would be from, let's just say, a colonoscopy screening program. If everyone in the whole population had a colonoscopy, what do you think the mortality reduction would be from colorectal cancer? Anyone is willing to sound out verbally, that's great. If not, if people could also, if someone, please feel free to type something in the chat. I see 40 participants, so I'm sure that there is someone. Ariel said 60%. Okay. 20%, 33. Okay, great. 40%. Thank you. The second question is one of the other things that we do a lot is surveillance. And let's just say everyone had a colonoscopy at the beginning, and then you had people who had high-risk adenomas. When do you think their next colonoscopy should be to actually demonstrate a decrease in risk of that person getting cancer? So the standard guideline would be 3 years. But when do you, let's just say you didn't do it in 3 years, how long do you think it would actually take? Does that person ever even really need a colonoscopy again? When do you think that, models and things would suggest that they should have a follow-up colonoscopy? 10, 8, great. So why don't we kind of go ahead and launch into this? Can people see the screen? It should appear as the full slide.
Yeah. Mm-hmm.
Great.
You see your presenter here.
So we go after obvious targets to decrease colorectal. Oh, it shows the note. Thank you.
Yeah, sorry, I see a slide screen here as well.
Yes. Let me just see. How about that?
Yes, perfect. Thanks.
Great. So, we go after obvious targets to decrease colorectal cancer screening, but if this doesn't work, really, what do we do? So this kind of shows patterns in colorectal cancer screening, and you can really kind of see going, through the 70s and into the 80s, things were pretty flat. And that was when colon cancer screening started to be able to be introduced, and there was this steady decline. And there have been models that have been put out about well, what were the things that were contributing to this decline? And the biggest single one of them was an increased uptake of screening. But the challenge is that even if you go after these obvious targets, what do we do? So this is kind of where in 2020, so far after that modeling study was done, where we are with colorectal cancer screening. Still the second leading cause of cancer death in the United States. Lung is obviously way up there. But one of the questions then is well, people had talked about, what they thought. Let's just pick one of the larger numbers, like the 50% reduction. If you had a 50% reduction, then those kind of interval or missed or cancers that would be happening despite screening would still be equivalent to all of the lymphoproliferative cancers. So colorectal cancer here, decrease it by about 50%, and then kind of look over where these other cancers are. It would still be probably 50% more than all of the kidney cancers. So still a lot of cancers. So then the question comes to, are there ways that we can decrease, cancer deaths further? So I'm going to go over 4 controversies fairly rapidly in colorectal cancer to be able to really kind of hit the highlights, especially given our audience here is gastroenterologists, who really are very familiar with many of these concepts. I am going to note that almost every single slide, almost every single study that I'm going to show has been published within the last 2 years. Almost all of them have been published during the pandemic. So this information really is new, and hopefully there'll be something that will be of interest to almost everyone. So the first one is does screening work? That was one of the questions that came up in that New England Journal study, and we'll touch base on that in a second. But to be able to think about that, we should probably think about what are the main screening tests and the evidence. I'm not going to go super deeply into this because these tests are generally familiar to this audience, but they've been, historically sigmoidoscopy, fecal occult blood testing, which is really actually looking for an oxidizing reaction to blood in the stool. Fecal immunochemical testing, which is actually a specific immunochemical test to fecal hemoglobin. Colonoscopy, so conceptually, that's kind of a long sigmoidoscopy, being able to look at the whole colon. And then what's called Cologuard, which sometimes people think of as a single test, but it's actually 2 tests. It's the FIT test, and then it's also a DNA test. Most of the cancers are actually being picked up by the FIT test. And whenever you combine 2 tests, you're always going to have increased sensitivity. You're going to pick up more things. One is going to pick up some things the other one didn't. And you're going to have typically you're going to have decreased specificity as well. One of the big strengths of the Cologuard test is that it has navigation that goes along with it. So that means that from the company standpoint, they will help send the test out, and they'll help to be able to do the follow-up. It's also lower frequency. It's recommended every 3 years. So again, there's not really a lot of things that follow up that have evaluated that interval. And it's a little complicated. I'll talk about how in models where it fits in, but it actually is what's called dominated by fecal immunochemical tests in these cost effectiveness models. That means that it's both less effective and it is also more expensive, which is why it's dominated. Now, the tricky thing is that the things that we have the randomized trial. So I think we can clearly say that colorectal cancer screening is effective. There have been in randomized trials for FOBT and sigmoidoscopy demonstrated effectiveness. The challenge is that neither of those are things that we use right now. So everything then kind of comes from these indirect tests or indirect studies that well, FIT does the same thing as FOBT and it's more sensitive and more specific, so it must be good, it must work. Colonoscopy looks the whole way around instead of part of the way around, so it must work. And also, it's the only test that came up after a FIT or a FOBT. It was actually the test that did something, it detected. So that, theoretically should work. And then the FIT DNA is really further indirect evidence, kind of similar to what the FIT test has, but there's less data around it in terms of large case control or other studies. So we're mainly going to focus on FIT and colonoscopy. Those are the two most commonly used around the world. So, and then what happened? So this was October 9th. So just 10 days ago, there was the study in the New England Journal with the interesting title of Effect of Colonoscopy Screening on Risks of Colorectal Cancer and Related Death. So many of you have probably heard about this already. I'm going to go into a couple of the details, including some of the things which are in the appendices that kind of help to be able to explain it a little bit more. The biggest thing probably about this is that it generated a lot of news. And a lot of the news around it was around the effectiveness of colonoscopy. Like that's what the title suggested. It even went on Saturday Night Live with Shay. Benefits of colonoscopies, kind of like overestimated. So that was kind of like the initial story around it. The realistic thing is that the title probably should have said something else. It probably should have said effect of invitation to colonoscopy screening on risks of colorectal cancer and cancer death. So what does this study look like? They took a large number of people, and this was in Sweden, Norway, Poland, et cetera, countries that did not have a really high, and again, this was started more than 10 years ago. So especially at that time, did not have a high use of colon cancer screening. And they randomize them to what they call the colonoscopy group and the no colonoscopy group. This is actually not correct. They randomize them to the invitation to colonoscopy group or the no invitation to colonoscopy group. And so what happens down towards the bottom, where you see these included in intention to treat analysis, those are people who were invited, those versus those people who were not invited. And so 42% of the people accepted the invitation. And I've been in communication with the authors over the last week, and they understandably felt like, that's a pretty high participation rate, from a population level initiative. But what happens then is like all of the people who are accepted in the intention to treat get averaged in with the people who were not, who did not accept the invitation. So right off the bat, if there's an advantage to colonoscopy, you would expect that it would be, over 50% diluted by the fact that half the people didn't get the intervention. So what happened then? Well, so this is the cumulative incidence, and this is actually in the appendices, so it's in a little bit of a different place. But one of the questions with it is like, well, what did these people look like? So there's 3 lines here. The first is the no screening group. So those are actually the people who were not invited, no screening invitation. And as you might see, they kind of just have this continuous slow line that kind of goes up, in their risk of developing colorectal cancer. Next is the non-participants line. So those are the people who actually were invited, but they said no. Interestingly, that group of people, as you can see over the course of this, looks like they're actually trending towards being lower risk than the non-screening group, which then gets to the question about the participants. So the participants have what you might expect to see in terms of a curve for an effective test. So if the test was effective in finding colon cancer and in preventing future colon cancers, you would expect that you would detect a bunch of cancers earlier, and then that would actually flatten off because you've detected the cancers. And then interestingly, and this is something very unique to colonoscopy, not the case with mammography, which is just early detection. In that case, you would just see more cancers. You wouldn't see any flattening off because mammography doesn't prevent cancers. But colonoscopy can prevent cancers theoretically by removing polyps. So can actually this has been demonstrated for also for fecal occult blood test in the randomized trial. So that line then that you see is kind of what you would expect. But the interesting thing about this graph is that it suggests that there may actually be a bias, that the people who were the participants were actually higher risk than the non-participants. So that's just an additional kind of twist with this. But keep that green line in mind as we move forward. Overall, what they found in the intention to treat analysis was about an 18% reduction in incidence between the invited versus the non-invited arms. And that's taking into account that only 42% of the people completed the test. And the mortality was not different between the 2 arms. So for incidence, they said the number needed to screen to decrease to one cancer was 445, and there's no difference in kind of the all-cause mortality. So they also try to be able to do these adjusted per protocol analyses. So with these, it's actually they didn't really talk about how they did this that much. They went into it more in some of the appendices and in the protocol. But in a nutshell, they did some adjustments, and they made an assumption like, what would it look like if everyone in the invitation group had similar results to the people who were invited and completed the exam? Now, that's a little bit of a tricky thing to do because, as I mentioned, there's differences in risk. So essentially, you're saying, what do they look like compared to the high-risk people? But nevertheless, they did these analyses, and these were the cumulative incidence. And per protocol, the incidence looked like it was about a 30% reduction, and the mortality was about a 50% reduction. Does that make sense? Okay. So the mortality pattern, this is also in their adjusted analysis. This is just kind of like, I showed you the pattern of incidence. This was just kind of like the pattern of mortality in their per protocol. In the non-per protocol, the lines were kind of like were pretty close. To each other, and actually had a little bit of that kind of like same odd thing where it actually went a little higher, trended higher in the group that was invited and accepted. So the conclusions of this really are first that there's if you invite people in an largely unscreened population, you'll have moderate uptake. Actually, pretty good, 40%. You think about the pandemic and inviting people for getting vaccinated. Just a single invitation, getting 40%, in any intervention is actually pretty good. The patients completing the screening were likely at somewhat higher risk than those who did not, which then creates a little bit of an interesting thought problem, for how you interpret the results. There were fairly modest population level benefits, really no mortality benefits overall, and a moderate decrease in incidence. If you made the assumption that like, oh, what would happen if everyone got it? Those were closer to maybe like what people were expecting, like about a 50% reduction. And so these were probably influenced by participation. Other factors to consider, if you remember that green line, there are long lag times for colorectal cancer incidence and mortality. There may have been some things around generalizability. The quality of exams, as we'll talk about a little bit later, like adenoma detection rate, was like reasonable for like that time period, but it's higher now. And they also didn't have a lot of data on what happened after people had things found, in terms of surveillance and treatment. So does anyone have any question? Oh, that's a good question. One of them, the prevalence of CRC in the Nordic region, it varied. So some of the countries, and I apologize, I don't remember off the top of my head, actually had lower incidence than some of the other ones. So they did kind of break it out by country, but that kind of influenced some of the rates as well. Were there any other, I'm not going to go in a lot more detail into the Nordic trial. Were there any other questions around this? I see that, I apologize.
Pooja has a hand raised. Pooja, go ahead, unmute yourself or just type your question.
Oh, I'm so sorry. That was an accident.
Okay, great. And, really welcome the verbal questions. It's much easier to be able to answer in some ways, and you probably can get it out faster. So what happens in the United States? Well, so this was a study that we had done in Kaiser Permanente. This was published a few years ago, and it says more or less, if you look at the shape of this line, if you kind of remember that green line, this is pretty much similar to that. So if you're saying what happens in large populations, is it similar to what you saw in this randomized trial? The general answer would be yes. So this is what the cancer risk was in years after a negative colonoscopy result. So the 1.0 is the unscreened population. And then within Kaiser Permanente, this is people who had a colonoscopy for any reason. So it could have been FIT positive. It could have been really any reason. And screening, anything, iron deficiency, anemia, what happened to those patients? And up through year 5, you can see there was about an 80% reduction in the risk of colorectal cancer And even then, when it kind of starts to tick up a little bit, maybe in years 8, 9, and 10, but it's still actually, even in those time periods, going out to years 12 and greater than 12, a greater than 50% reduction in colorectal cancer risk. So, this isn't a randomized trial, but it shows fairly similar data to what they found, suggesting, again, that if you applied what they found to a larger population in the randomized trial, very similar patterns. The other, so this was published in the New England Journal a little bit earlier this year, which was looking at well, what happens if you increase cancer screening rate? Can you do that, first of all? So we made an effort that over the last couple of decades to be able to do that. And through a combination of FIT outreach and colonoscopy on request, so it's a combination of screening, colonoscopy, and if you're not up to date, you get a FIT mailed to your house. That's where you see this change from 2006, when the mailed FIT program was implemented. Sigmoidoscopy was phased out, and colonoscopy was phased in as the endoscopic screening test. And what you saw was that for both non-Hispanic whites and Blacks, there were relatively similar 40-ish percentile screening rates in the early years, and then it really went up to greater than 80%, pretty close for both of those groups. Just note that's a little bit of a lag. Look at 2009. You'll see that among non-Hispanic Blacks, they reached this kind of 70% rate around 2010. And in non-Hispanic whites, they reached that 70% rate in around 2009. So if you're trying to be able to see, look at kind of for cause and effects from as much as you can from observational data, this is, I'm just going to show you something kind of that looks a little bit at that. So what happened? Well, as you can see on the left side, especially among the non-Hispanic whites, the blue line, we had been kind of bumping along at about 40% screening rates for quite a while. KP's had a colonoscopy screening program that was FOBT and sigmoidoscopy without a lot of other outreach. And you can see that the incidence rates for colorectal cancer were pretty steady among that group. They were going up among non-Hispanic Blacks. I'm not quite sure of the reason, for that. It could also be partly that there was some increased outreach or screening like a few years before, but nevertheless, pretty substantial differences. If you look at the incidence rate in 2006, it was around 150 in non-Hispanic Blacks, and it was around 110. So, almost a third higher. So what happens then? Well, all right, well, those screening rates go up from 40 to 80%, and what you would expect to happen, happened. If you look first at the non-Hispanic whites, you'll see that the cancer incidence rate went up by about 20%, peaking in around 2009, and then it started to decline. Same thing among non-Hispanic Blacks, except the peak happened when? 1 year later. Again, also just suggesting that these are related to those screening effects. But the remarkable thing is then what happened over the next 10 years. And again, colorectal cancer has a long lag time. It also takes a while for polyps to turn into cancer. That would be on the incidence side. And so what you're seeing on the right-hand side then around the last few years is, first of all, in both incidence and in mortality, these disparities, these differences between the two groups went away. The second thing is that it just fell a huge amount. If you look at what the incidence was among non-Hispanic Blacks, even before screening went up around 150, it went down to around 80. So the incidence fell almost in half. And the same thing happened with mortality. If you look among non-Hispanic whites, where the drop was less pronounced, it went from around 40 to around 20. So about a 50% reduction. And this is not even with 100% screening in the population. So this was fairly compelling, given that there weren't a lot of other things going on within the population, and we had that clear change with the screening, that it was likely related to the screening, although this is not a randomized trial. So I'm going to go on next to kind of the which is a screening test is best. Were there any questions around those results, or around any questions if whether screening works? is what we do on a daily basis actually worth anything? And I hope actually that that's to our group and to when I give this talk to others, you should just feel really awesome about what you're doing on a daily basis, that you're taking essentially these systems look like what we're doing is taking the second most common cancer, and within just like a 10-year period of time, decreasing the number of cancers and deaths by 50%. There's really nothing else which is like that. Mammography, in terms of those early guesses, mammography decreases in randomized trials around 20 or 25%. Again, these are not randomized trials, but we have done high quality case control studies and other things that suggest, and even within the per protocol analyses from the Nordic trial, suggest that the reduction is probably like at least 50%. Okay.
So Doug, this is Tanya. Maybe you can just take a quick moment. Why is the messaging then so difficult for colon cancer screening? Like, despite these advancements and, observed reductions and such, why is the messaging so hard relative to mammography or lung cancer screening now or things? I mean, so can you just comment on that?
It's a great question. I think it's a little bit of the nature of the test. I think the test is kind of embarrassing to people. It's invasive. You have to take the bowel prep. You don't really see a lot of jokes on Saturday Night Live about mammography. But if you look back and just putting colonoscopy Saturday Night Live under YouTube, you'll find several actually, not just the one that I showed, of clips around colonoscopy. And so I think that that's part of it. I also think that there's a matter of time. So if you think about another common test, which could, initially be perceived as embarrassing, which was Pap smears, it took a while when those were started in the 1950s and 60s to get to the point where people are like, oh, I'm going in for my Pap, and it became kind of like a comfortable matter of discussion and actually a matter of encouragement. I do think we're in that phase. And to the point of in the comments, being able to talk to someone from Poland, by the way, it was mentioned preventative care isn't really a culture there. People feel what happens. And so I think that that is part of it in some settings. And then also even within the United States, I mean we have gotten to 80% screening within KP, and I think that's partly just because it's part of the culture. You're not screened, you're going to get a fit test in the mail every year. It becomes part of the discussion. So I do think it takes a little while, but that we are getting closer to there. And at least before, like Katie Couric and Ronald Reagan and other people who were willing to talk about it, made it like an acceptable thing to be able to talk about at least. And now I think it isn't an acceptable thing to be able to have done. But a huge amount of it is on the implementation side, as you're alluding to, not necessarily just around the test. Anything else? Okay. So this is a list of all of the randomized trials comparing colorectal cancer screening modalities. Yes, it is blank. So there are no trials, as we know, even comparing colonoscopy to nothing or FIT to nothing. So we have nothing really that compares. So all of it is somewhat speculative based on these other studies. And it takes it one more degree removed to modeling studies. So I will talk about those because I think that they're helpful. This is almost everything I'm going to be showing is from the CISNET collaboration. That's from the National Cancer Institute. This one is from all of the CISNET centers. There's several of them. They kind of average their results. And then from one of the main CISNET centers as Erasmus, which is the one that has had the main U.S. Preventative Services Task Force information provided from it. We have ongoing collaborations with them, and so I'll be showing some information from them too. So I'm only going to pick, I think, maybe the three main tests that are talked about now. I'm not going to be talking about Septin9 or CT colography or like some other things. I think the main ones that are kind of like in use, and I'm going to be talking about the most common patterns. So that FIT every 1 year with all of the test performance as well as compliance things around that. Colonoscopy, same thing with compliance and test performance of having an exam every 10 years, and FIT DNA every 3 years. The 3 years in particular is very speculative because unlike these other tests where we have a fair amount of information of what's it look like after 1 year or 5 years or whatever, we don't have that much around this, so it's relatively speculative. So there are 4 different things: complications, colon cancer is averted per 1,000 people screened over their lifetime, and colorectal cancer deaths averted, and then like how many colonoscopies would that take? With the assumption that each of these tests is a little bit of a burden, but the colonoscopy is just kind of an order of a magnitude greater burden than doing a FIT test, but not a zero burden having to do that at home. So first of all, Complications, per 1,000 people screened, about 12 people, so about 1 out of every 100 people would have some complication over the course of their life. Not all of these are like really serious complications, but some of them are, perforation, bleeding, things like that. So it's not a trivial number. We often think of complications, I think, as rare with colonoscopy, but when you're multiplying, starting screening at age 45 and people getting multiple exams over a period of time, at the minimum, it's like having 3 colonoscopies at 45, 55, 65, and then stopping screening at 75. You get a multiple, it's like your cumulative risk, over time, so that multiplies. Colorectal cancer screening averted is the next one, 50. Wow, that's a pretty impressive number. If you think about it, we're talking about 1,000 people. So 50, that's like 1 out of every 200 people you're preventing a colorectal cancer in over the course of their life. I find that to be pretty impressive when I'm talking about people. And to our previous discussion, it's when people are like, is this worth it? It's like, well, I don't know, 1 out of 200. That's just for your cancers averted. Deaths, 26. So, now we're talking about 1 out of every 500 people not dying from colon cancer, and this is with FIT. And then colonoscopies, well, that's quite a bit, 1,600 colonoscopies, over the course per 1,000 people screened. So let's kind of go a little bit more quickly through some of these other ones then. Colonoscopy every 10 years, complications about 16, not quite as big of a jump as you might expect. But that's partly because the people in the FIT arm were more likely to have polyps and other things that are a little bit higher risk. Cancers averted. This is where there's the main difference between FIT and colonoscopy. Colonoscopy is better at taking out polyps. That's better at cancer prevention, so that there is an increase as opposed to decreasing cancer death. Cancer death, pretty similar, 26, 28. And colonoscopies, obviously like a lot more. So, partly is just like how you value and how patients value, the substantial additional burden of the colonoscopy. Some people don't care. Some people don't want to have a colonoscopy done and they won't be screened. Studies that have looked at systems or even randomized trials, John Inadomi, when he was at San Francisco General Hospital, did a randomized trial of invitation to FIT or colonoscopy or giving people a choice. And in general, if you have a choice, both are being offered, you have a higher screening rate. And that's how every system that has gotten to screening rates greater than 80% offers both FIT and colonoscopy, so that if people don't want to have one, then they can have the other. So if you recall before, I said that there were some real advantages to the stool DNA test, and that those, a lot of them are around navigation and kind of the additional support, and it's every 3 years. But if you have perfect compliance, how does it look? Well, it's dominated by these other strategies. So first of all, it has slightly more complications than FIT because it requires more colonoscopy, because it's less specific. It has more false positives. It has slightly fewer cancers averted than FIT and colonoscopy. That's partly because it's done every 3 years instead of every 1 year, even despite with the increased sensitivity. It has slightly fewer cancer deaths averted for the same reason. And it has about the same number of colonoscopies because it has more false positives. So that's why it's a little bit challenging to be able to evaluate it. But if it does have the advantage of not having as many, you only have to do it every 3 years. So we did this one other study that was published in Gastroenterology a couple of years ago. I'm just saying that, like, well, then why do people die from colon cancer? Among all of, in a setting that has a lot of screening going on. And the long and the short of it is, if you look at the orange and the yellow, it's because people aren't screened. Almost all the people who were dying had never been screened, or they weren't up to date with their screening. There was about 25% had a test failure. So those are the people who might have had a post-colonoscopy colorectal cancer, or they had a colon cancer that was fatal despite having regular FIT tests. Look at the surveillance one. Almost none of them was because, wow, they didn't come for their surveillance exam at 3 years, as they were supposed to. And a moderate percentage were because someone didn't follow up on a positive screen, like had a positive FIT test, but they didn't follow up. But that is a pretty high risk group. So does surveillance matter? where should we really be directing our efforts? So there's two parts of this. There's both repeating screening, and then there's also the question of surveillance. So I'm mainly going to tackle the one on surveillance. The screening one is an interesting separate one that was part of the guidelines for decreasing it to age 45. But in general, it's thought that at least it's cost effective, to be screening people every 10 years. Just pulling this back up a second. After normal colonoscopy, this is going to be our comparator. This is like what your risk pattern looks like compared with that 1.0 line. This is what the cumulative cancer incidence looks like among different risk groups. So on the bottom, that's the no adenoma group. So remember, that's the group that has, like between 20 and 50% reduction in cancer risk compared to the unscreened population. The low risk adenoma group is essentially identical. The low risk adenoma group, those are the 1 to 2 small adenomas. And then there's the high risk group, which is higher risk, but it's still actually not nearly as high risk as the unscreened population. So this is what, in general, like the absolute numbers kind of look like. Again, like the low risk adenomas. So no adenoma, that's kind of like the reference, your low risk adenomas, and then your high risk adenomas. And that's your hazard ratios on the left for developing any cancer and your hazard ratios for death on the right hand side. So for serrated polyps, just very briefly, it's pretty similar. Distal serrated polyps, proximal a little bit, the small ones have a little bit more risk, probably because we weren't as good at it, taking them out. A lot of these work was from a while ago. This is the part that I find interesting. So that same modeling group took a look at this, and they said, well, okay, look at that solid line on top. That's someone who had they got one screening colonoscopy, and they had no return to surveillance, no return to screening. If you had a low risk adenoma, how long would it take for you to be able to notice a divergence? And it's really after about 20 years, it took to be able to find a divergence in your risk of cumulative colorectal cancer incidence. It's even farther out and smaller for mortality because that's a more rare outcome. How about for high risk adenomas? The average risk for people was about the same. Like you never did, like your level of risk was a little higher in that black line, but it's still kind of about the same thing. It really took like about almost 20 years for you to be able to have much of a difference. So what the real message of this is, of all of these slides kind of cumulatively, is that the people who are at the highest risk of dying from colorectal cancer are the people who have not been screened, not the person who was supposed to be rescreened in 3 years, and oh my gosh, they are like 6 months late for their repeat colonoscopy. Those people are at higher risk. It's worthwhile for that particular group, but it's not where most of the things are coming from. Now, the recent guidelines have changed. I think the main thing is this one, which is in the middle where it says 3 to 5 years. That's kind of like the 3 to 4 adenomas, potentially having up to 5 years. But I want to show a little bit more kind of interesting definitions, really whether we need a new definition of high risk. And this was a study that was published in the last couple of years. So they kind of looked at the current low risk and the current high risk. And as we're all familiar, like, high risk is more than 3 adenomas, or they're villous, or high-grade dysplasia, or they're greater than 10 millimeters. The thing is with this is that a lot of those patients, 36% of patients with any adenoma were high risk based on the current definitions. Most of those were because they had 3 small adenomas. So if you reclassify those patients, you take out those people, and the only people who you call high risk are those who have polyps that are greater than 20 millimeters or high-grade dysplasia. You move all of them into this other group called risk among those moved. Their risk is pretty similar to the low-risk adenoma group. The high-risk group becomes much higher, but then it really is a high-risk group, and those other people that were contributing to it appear to have not been. So, we're actually looking at this separately within the US population, but this may be part of a move of like who really is the high-risk people that need the earlier exam. So redefining the high risk as greater than 20 milliliters would decrease the high risk group by 74%, and really have, among those shifted, have almost no difference in terms of their risk prediction, and may reduce the harms and benefits of intensive, may reduce the harms while preserving the benefits. So the last topic area is, does it matter who does my colonoscopy? I'll go through this. I know people are pretty familiar with the adenoma detection rate. You know, many of these questions throughout this whole discussion, a lot of the information that we've been presenting, you know, has been from the National Cancer Institute's PROSPER Consortium. There are 4 colorectal cancer centers within that in Washington, Northern and Southern California, and UT Southwestern. And one of the main reasons that this pooling has allowed creation of kind of the largest U.S. database studies around this and in community-based populations. You do get a little bit different results in the VA population. They tend to be higher risk. So we had previously published in the New England Journal about adenoma detection rates and their associations with colorectal cancer incidence and death. Kind of an expansion that was just in Northern California, an expansion that covered all of those centers, really markedly bigger size, allowed us to use more contemporary adenoma detection rates, allowed us to look at more detail of adenoma detection rates that were above 30%, was published a few months ago in JAMA. And these are the results from that. In a nutshell, those 3 lines that are on the top, on the left is your cumulative incidence of post-colonoscopy colorectal cancer, and then on the bottom is time after colonoscopy. And you can see it just kind of continuous. It's even within 1 to 2 years, these lines start to diverge. But these ones that are at the top are basically if you are less than 30%. So it's less than 20%, 20 to 24, and 25 to 29. What's your target? What should we probably be looking for? It's probably greater than 30. And things started kind of to cluster together when you got greater than 35. Those are the lines that are on the bottom. Does that mean there's not benefits of having greater than 50, greater than 40? No, but some of those benefits might be happening farther out. Like if someone didn't get rescreened at 10 years, maybe some of those benefits would be more evident then, you know, may not be so evident within a 10-year rescreening interval. So overall, this is a lot of people. It's like 850,000 colonoscopies, 2.5 million patient years, you know, about 600 colon cancers, not that many deaths. But overall, the thought is that, and this is consistent with what we'd seen before, that for every 1% increase you go up in ADR, there was a 3% decrease in incidence within this short time, really within an average time of 3 years. So if you stretch that out to 10 years, that would probably be a much more substantial decrease in incidence and a 5% decrease in death. So I just think about this like, if you're just looking at your patients on average for a follow-up of 3 years, you're finding every 1 click up. So if you go up 10%, that's a 30% reduction in post-colonoscopy cancers within an average of about 3.5 years. And then again, a 50% decrease in related deaths. Just in terms of modeling, if you stretch this out over the lifetime, this is just reinforcing kind of what I had just mentioned. This is the same modeling group that was previously published in JAMA with the data from our system, that it's even bigger. And that the cancer treatment costs go down. The net screening costs actually go down because better adenoma detection rate doesn't really change screening costs that much. And it doesn't actually increase the number of colonoscopies by that much, like only by like 10%. In terms of how to be able to increase higher ADRs, more time alone doesn't work. I'm not going to go into this in a lot of detail, but in a long and short of it, like there actually were trials just trying to be able to increase longer inspection time. But careful inspection leads to longer times, which leads to higher ADRs. Just increasing longer time, say, hey, you need to spend more time, actually by itself, interestingly, doesn't do it. I actually don't measure my withdrawal time, but we do measure our adenoma detection rate. Some devices may help without going into a lot of detail. Things like the EndoCup, I actually don't have any commercial relationships with any companies, but have been shown to increase adenoma detection rate. And then the other thing is whether or not training can make a difference. We really haven't found a lot of training that can make a difference. There's been some randomized trials that have been unsuccessful. This is an observational study that is currently submitted that we had done that looks at kind of regional feedback plus an online training program that anyone can kind of do was created with a lot of discussion with kind of best practices. How do you get at the underlying drivers? And we found with this, in terms of the overall impact, that it improved the detection rate over this time period from 25% to 40%. That's the left side to the right side. That for the training alone increased it 5% for lower detectors. So again, if you think about that, that's a 25% reduction in mortality within 4 years. Markedly decreased variation, so we didn't have as many people who were like low to high. And if you're taking it from a cost effectiveness standpoint of doing a training that essentially is free, it led in our system to grade over 100 fewer cancers over 3 years, greater than $10 million in kind of cost savings. So what this is just this online interactive training. It kind of goes through a bunch of the different aspects that are thought to have the most impact on retention and actual change in behaviors. There was a whole behavior change study that went into feeding how this was structured. And a lot of it is partly around detection. It's kind of interactive. I think everyone's familiar with in this audience with some of these slides. On the top left, that's a polyp. It's mainly identifiable because there aren't any blood vessels. On the top right, that's another polyp. It's smaller. It's in the middle. And again, no blood vessels going through it, although it doesn't not so big in itself. In the middle, sorry, on the bottom left, a smaller polyp. It's kind of like at the end of that fold. Again, I'm sorry, not there in person. Can you see my pointer or no? Okay, so kind of there, here, and then here on the bottom right, the polyp, which is in this fold, looks a lot like that fold. Easy to be able to kind of like go by, but it's just kind of wrapped around that fold. So, in a nutshell, adenoma detection rate, get a good field of view, split prep, good compliance helps everyone, washing and cleaning. Devices may be helpful, especially in lower detectors. Training and focus and leadership, a quality program likely helps. Pathologist training actually helps to identify serrated adenomas, and these proven MD level interventions are likely multifaceted and straightforward to disseminate and replicate. So if anyone's interested in it, that's actually available for free. It's at kp.org/DARE under the GI Specialty Network. There's just a link on the right-hand side that has the adenoma training. So kind of winding this up.
Can I ask a question, Doug, about that training program?
Sure.
Did you have, do you have like a threshold or remediation? I don't want to use the word remediation, but do you allow providers to continue to perform colonoscopy if they don't meet certain benchmarks, and do they have like, do you have an ongoing like performance evaluation of the low performers? I'm just curious if that's was part of your study and your practice.
Yeah, I tell you, that's a great question. I mean, it wasn't part of the study because obviously that was kind of over a long period of time. Every single gastroenterologist actually took that training program. We're at the point now where we almost have no one who is below the quality benchmarks. But if you wanted to say, well, maybe the quality, what if you had a quality benchmark of, like 30%? We have not developed that. I actually do think that that's something that that should be, developed and in most settings, in a more formal way. I think it's, it's like one of those conversations, kind of beyond. We do provide feedback. We do actually calculate the adenoma detection rate. The screening versus the screening ADR is difficult in a lot of centers. And this current year, just a month ago, we changed to, rather than reporting screening ADRs, I'm reporting total ADRs, all colonoscopies. There's a whole bunch of data that we have behind this, some of it which is we're about to publish. You do have to adjust kind of like what your baseline is for lower performers, but that's something also we help to be able to publish. But then you don't have to do as much stuff with trying to be able to identify just the screening exams. But I would actually be interested, do you guys have a identification mechanism for lower performers in terms of them, like specified feedback and training?
Yeah, I mean, within the VA, we've developed a program to identify, ADR across the country. And we're working on programs to intervene on low-level performers after they get the original feedback, which would be, their actual performance and some of these different cognitive education interventions. but I don't think there's a formal, and when we've surveyed the VA, at least, very few have a formal evaluation plan, or like a remediation plan in place for low levels. I think in medicine in general, we just continue. It's very few places in medicine, right, where we have to stop practicing short of a malpractice suit, right? I feel like we have these benchmarks, but we kind of continue along the way, even if we aren't meeting them, is my observation.
Yeah,
So.
I mean, I think you're right on target. I mean, the interesting thing is, like, even with the lower quality ADRs, the people's reduction in colon cancer risk is tremendous. It's still like very large with that, but it's not really where it could be. I think within our system, both the chief knows who is at that medical center who is low, and it's kind of left up to them. But it hasn't been a system-wide. It hasn't been a system-wide practice beyond the feedback. If you're interested, I'd be delighted to talk with you more, kind of about this. I do think it's like one of the few things that's available to anyone, anywhere. It's 30 minutes. It's interactive. It's based on a lot of background data on best practices for behavioral change. And it is just kind of like a click away. Based on some of our early presentations with this has been adopted at some other centers where people are like, they're having like all of their fellows or all of the people who are there, kind of take it on a one-time basis, given like what the preliminary results that we had. Granted, it's not a randomized trial, but we found it fairly compelling. Which screening test is the best? Really it's the one that gets done. If you're, you can say that colonoscopy has a lower incidence rate, but if people are not going to do it, or you're not having a system where everyone is getting it, then, and they're pretty similar in terms of mortality reduction. So, in general, probably the best one is just like being able to, and that's what most settings who are trying to do this are offering both to be able to have it done. Does surveillance matter? Yeah, probably matters somewhat to the small number of people who are going to get cancers within those groups. But the actual overall risk on a population level is pretty low. And so if you're trying to be able to say, wow, should we be getting in this person who had 3 small adenomas for their follow-up exam, or should we be getting in somebody who is unscreened? It's better to get in the person who is unscreened. That's where most of the death, or is really not up to date with screening. That's actually where most of the deaths are occurring. And does it matter who does my colonoscopy? Yes, for both screening and FIT. We've done other studies that have looked at this for like, the impact on FIT. And of course, because FIT is followed by colonoscopy, the same thing happens with colonoscopy. On behalf of our teams, it really takes a village. This is just kind of across our groups, other centers, the NCI, et cetera. Thank you so much. Really such a pleasure to be able to talk with you. Glad to touch base with anyone separately from this. And any other questions, I would be delighted to go over.
Well, thank you so much, Dr. Corley, for this wonderful talk and all the updated info. So very, very helpful. Just a few notes from my side. It's very interesting to learn about that ADR training tool you shared, and seems like a great resource for our fellows as well. And at our institution at UCSF, yes, we do measure ADR, and we are about to launch a dashboard as well for ADR. And we are fortunate we do not have low performers. So so that is the current status. But my question for you is, for the Nordic trial, a lot of media headlines and many misleading, and we did see that there was 30% reduction in the incidence and 50% reduction in mortality for folks who did undergo colonoscopy. Should they have revised the headline, as you said, and how do we get this messaging out to the general public and our patients that it's the invitation to colonoscopy that was not effective? It's not just the colonoscopy, the misinterpretation that has happened. How do we undo that?
Yeah, I think it's really hard to undo. Interestingly, though, to the media's credit, as I was looking for headlines to include in the slides, I actually found a lot of stuff kind of came out on the first day, and then there was more stuff about media misinterpretation of the colonoscopy study, than there was. But I don't know that that's actually going to, move the needle. I don't think that public people are not going to do it. I think it causes a little bit of a tempest in a teapot, probably more within GI, than other places. I'm just there's a couple of Tria had said, can you talk about stopping screening, especially stopping surveillance, any data on taking account? These are great questions. And I mean, and there's not really a lot of data. I would just say, keep your eye on this space. We actually have 2 studies that are currently, in analysis that are looking at this. One is just, I can't remember if it just got published or is about to be published. Basically looking at this question, if someone's screening up to date at age 75, like what happens? And what happens if they had like 8 negative FIT tests, versus they had like 1 negative FIT test 5 years ago. There's obviously like a lot of different scenarios, but if you keep your eye on this space, I think you'll have some information about it, which is that, yes, those people are lower risk. Is it lower risk enough to stop? Probably if they had a recent colonoscopy, like if they had a colonoscopy between 70 and 75, that's just going to be carrying them into their 80s and beyond. The only thing is that cancer risk really goes up a lot with age. So you're kind of like, you're kind of having these competing aspects. But great question. Zoe had asked a question like, would you give the same advice in regard to the best test you take in patients with a relevant family history, or would you advise colonoscopy? Yeah. So the question about like risk. So the standard guideline is that family history people should have a colonoscopy. That's the standard guideline. Those people are at increased risk. There's interesting information about this in that most of that risk happens at a young age, and it's of a relatively low amplitude in terms of, so when you're at age 45, your risk of colon cancer is pretty low. If you have a family history, it's double. So it's like double a low number. When you get up to age 60, your risk of colon cancer is like several times higher than it was when you were 45. But the contribution of family history gets totally swallowed in the fact that your general risk has just kind of like gone up. So the Utah group had done a look at like the contribution of family history. And by the time you're at age 60, if you have not had colon cancer yet, and your mother had colon cancer at age 53, by the time you're 60, if you haven't had colon cancer, it doesn't really contribute much to your risk beyond like what your baseline risk is. So it is important probably for the initial screening, but it's not as important kind of later on. Again, that's just a little bit of a factoid, I think that kind of gets ignored, but it's more about starting screening. But interestingly, the moving screening age down to 45 has absorbed a lot of the family history risk aspects because most of those people get captured. Yes.
I think Alec is asking for the link. Yeah, we'll be happy to find that and share that with the Grand Rounds link, with Grand Rounds mailing list. I can follow up on that. Any other questions?
I also put it in here too. I put it in the chat. Oh, it said I don't know if that was a direct message or not. That went to everyone. But.
I'll follow up on that.
Okay.
Any other questions anyone would have for Dr. Corley?
Great. I know our time's up, and please feel free to contact me directly. I'm happy to be able to go over any of this, or if you have other questions, other ideas that you're interested in being able to collaborate on, and look forward to seeing everyone somewhere in person again.
Yes, and thank you again so much. Appreciate everyone joining us this morning. And Dr. Corley, thank you for helping us, just read through that article and data and how do we interpret that and explain to our patients. It was extremely, extremely helpful. Really appreciate your time. Thank you, everyone.
Thank you. Take care. Bye-bye.
Bye.